As you can see, I hail from New Orleans. I swam in last night. Arms are ridiculously tired right now. But here's the problem here. Our traditional model is really geared towards acute diseases. And when you take a look at what we do in clinic, that's not the case. Our clinic practice is really, I like to consider it a vestigial organ. It's obsolete. It's like an appendix. Most of the diseases that we see, heart disease, hypertension, high cholesterol, coronary disease, atrial fibrillation, all of this is really chronic stuff that you don't really need to actually physically come in to see a physician. And with the technologies that we have, we started implementing these wearable technologies to actually manage patients remotely without actually having them come in. So we started this digital hypertension medicine program about 6-8 months ago. And what we did here, this is low-hanging fruit. Hypertension is one of the most prevalent chronic conditions here. And within our electronic health record, we are able to find the populations who we share the risk with. And we have total, we can see all of their healthcare costs all bundled into one. And what we originally looked at when we looked at these populations is that they weren't managed well. They basically paralleled national statistics. So we came up with a new model. Instead of patients actually coming in, we can get frequent data points. The patients can monitor their blood pressures from home. That can be directly imported into our electronic record. We have an analytics engine that's tied to what we call an integrated practice unit. And this IPU, as you can see on the diagram there, consists of not just one physician, but it is a group of people armed with the technology they need to be able to make change to the patient rapidly. Typically in clinic, check your blood pressure, here's a med, come back in 3 or 4 months, we'll do it again. Here we're getting real-time data, and we're able to make changes very, very rapidly. One of the earliest things that we learned is that the patient's social network, who did their grocery shopping, how many patients live with them, or how many other people live with them, who picks up your medicines. Okay? All of this is more important than the medication itself. So what we did in this original pilot program is we had our electronic health record Epic scrubbed patients with certain insurance, the ones that we were at risk with, and we found those patients who did not have controlled hypertension. Okay? We had a list. We sent that list out to the patient's provider and said, is it okay? Would you like to sign this patient up for our program? The message went out to the patient all electronically. They were able to sign consents online, watch videos, answer questionnaires, and then they actually picked up a blood pressure cuff from our O-bar. And I'll show you what that is in just a moment. That is our O-bar. We basically set this up so people who are not technologically savvy can stop by, they pick up their cuff, we have a technologist there that essentially gets them plugged into the system. So all that they do is go home, check their blood pressure, and it automatically comes to us. Every reading that they take immediately, live, real time, comes to us, and we can make adjustments. In addition, that intake screening of all the questionnaires that they answer looks at all of these different variables. And you'd be surprised at how many people's hypertension, with hypertension, are actually depressed and need actually psychiatric or medical care. How many people actually have sleep apnea that's undiagnosed. Okay? So all of these different variables we look at with this program, and we treat them if needed. So we have 2 different aspects. There's the lifestyle aspect that we're going to deal with, and then there's also the pharmacologic intervention that we do. And this is a screenshot that comes directly from our what we call mission control from Epic, and this was internally built and created But this is everything you need to see on one patient. The top is the list of patients. The blue click is, the blue highlight is the patient that is then looked at, and you can see the blood pressure readings over the last several days. In addition, you can see some of the other, the medications that they're on, whether or not they're depressed, et cetera, whether they've been worked up for sleep apnea, et cetera. And this is exactly how it looks, and we basically have pharmacists who man this, who work with physicians. So you can think of this for those of you who are in the medical field, this is like Coumadin Clinic, where the physician enrolls and the pharmacist deals out treatment under the physician guidance. These are, again, two other patient examples here. You can see some of these patients, the icons listed there shows that there's been a psychiatric screen. The patient might have problems with medication adherence. Okay? So we get these monthly report cards sent out to the patients. We can also give them real-time feedback very, very easily. And here's our data. So baseline, nobody is controlled by definition. And then within 30 days, we get about 41% control versus the control group, which is standard of care. And now we're at 60 days up to 60% control. Now, when you actually think about this and look at this long term, we're doing this right now at a cheaper cost, but for every patient who gets blood pressure controlled, that reduces their risk of cerebrovascular disease and coronary disease multifold. So you're now actually, by controlling populations like this, long term, you have cost savings and better outcome data. Okay, now the second project that we had worked on was a heart failure readmission. And for those of you in the industry here, heart failure is the most common reason for admission into a hospital. The costs are, as you can see, $37 billion, and it's just getting worse. The prevalence is increasing. Now, the funny thing is that patients who come in with heart failure, about a quarter of them will return for admission within 30 days. Not all of them with heart failure, but many of them with heart failure. So this makes an obvious thing that the government can do, which is says for the CMS patients who do come back in, we're not going to pay for it. So there's now a huge incentive to reduce your readmission rate for heart failure. So what we did is we took a very comprehensive and standard approach to all the heart failure patients, and we essentially we phenotyped each patient and tried to figure out how we can reduce that patient's readmission within 30 days. And we monitor their daily weights. We send them from the hospital with a wireless scale and a router that is already self-configured. All they have to do is take them home and turn them on. And these are some of the metrics that we are looking at here. Can you afford your meds? Depression. So all of these different things are screened before the patient leaves. If the patient is depressed, they get a psychiatric consult and follow-up before the patient leaves the hospital. If they can't afford their meds, we actually give them 30 days worth of medications before they leave. Health literacy, it's standard that you have to provide a patient with a discharge instruction and say, here are the medicines that you have to take. Well, does it surprise you that many patients don't have reading level beyond that of a 7th grader? So you can give them the paperwork, but if they can't read it, they can't follow the instructions. Okay? So all of these things we look at, and obviously dietary sodium for heart failure is probably one of the most important things. So we have to find who makes their food, who cooks their food. So as soon as the patient is identified with heart failure as their admission, this sends a trigger. We actually go to the patient with an iPad or similar device. They fill out questionnaires, which tests their literacy in all of the topics that I just went through here. And then it puts it gives us an idea of, is this patient at risk for readmission? Is this patient at a lower risk than this patient, et cetera. And this is exactly what happens when they come in. As soon as the physician puts the admission in and the admission falls under heart failure, this immediately pops up. It is self-populated. Maybe a couple questions needs to be answered, and this patient is at a low readmission risk. Okay? They get enrolled, we will go out and see the patient, and this patient will still leave with the scale and the router. And as you see, the pharmacy is consultant, psychiatry, nutrition, everybody is consulted up front. Now, all of this, I want to mention, is completely integrated within the chart. Okay, so their phone, the scale, everything is 100% integrated so that it is real time. And this is exactly what we do. We look at the social network, their education, how much exercise, their diet planning. All of this is done on a daily basis for all the patients who are at risk for readmission. And as you can see, our results very, very quickly, we dropped readmission to about 14%, which is a little bit more than half of the national average. Okay. So a 44% reduction. Okay. And for this, I had to leave with a little bit of some Star Trek because, come on, we're all geeks here.
What's the matter with you?
Kidney dialysis.
Dialysis? My God, what is this, the Dark Ages? Here. You swallow that. And if you have any problems, just call me.
Okay. So if we were wondering what the future of health will be looking like, I don't know if that will be the answer, but I suspect that there will be a lot of wearable technologies that will directly interface with whatever electronic record the patient is associated with, and it will be real time. There will be less clinic, and clinic will mostly be acute care. Okay? Thank you.
Thanks. One question.
Oh, yes.
So you're amongst the first to get this sort of implemented in with your EMR and wearables. What's the pushback from clinicians, and how do you better engage them to start using this in their clinical practice?
So that's actually a great question because the physicians who tend to push back originally tend to have a little bit more gray hair. That's just an observation. So the groups that we start in, we tend to pick the younger physicians to start up with. And then there's word of mouth. And that word of mouth makes a whole difference as it gets up to the grayer physicians. So now, in the hypertension digital management, the physicians who originally maybe were a little bit more reluctant are hugging us. They love this. It opens up their access. They get better results. It is a win-win for everybody.
And the financial incentives with value-based care, you may get a bonus at the end of the year if your panel of patients have good hypertension or blood sugar control.
That's correct.
Right.
Plus, being that we're seeing them less frequently, there's less patient copay. So this is a gift that keeps on giving.
Great. Okay. You'll find Robert and Julia and I know at the breakout sessions this afternoon to learn more. Thanks a lot.
All right, thank you.